So, do steroids cause kidney scarring? And if so, how do you prevent it? So that's what I'm going to discuss today. So I'm Dr. Downey, and thank you for watching this video. So this topic came up to me because I came across an interesting study in 2010 where bodybuilders who were in the casualty, well, bodybuilders specifically, and those with a known history of anabolic androgenic steroid use were looked at, and they had symptoms that were similar to those with impaired kidney function. So they took these steroid users and included them in the study, and they found that 9 out of 10 of these individuals had something called focal segmental glomerulosclerosis, or for short Fsgs. So this is essentially where there is injury to the glomerulus, but more specifically, you have the blood vessels in the glomerulus, which I say it weirdly, but you have the blood vessels that are then filtered out into the nephrons, and then, but obviously you don't want everything filtered out from the blood vessels because you know your kidney filters things. So you have these cells called podocytes, which essentially wrap around these blood vessels and create a filter. Now what happens in FSGS is that there's damage to them and there's effacement of these podocytes. So that's essentially what it is. And this effacement leads to damage of the actual vessels themselves, and this leads to scarring, also known as glomerulosclerosis. So this may make you a bit worried because 9 out of 10 of these bodybuilders had scarring of their kidneys. However, the incidence was high because these individuals came in to the casualty with renal or kidney specific complaints, and there may have been selection bias in that. The doses were not really expanded upon, except one who was cruising on 1 gram of test a week, so not even blasting. So that was just interesting to note. So I then came across a separate study in Saudi Arabia where they had 22 patients who were also referred to the nephrology unit, and they were bodybuilders with a history of steroid use and had used GH and things like that, and 8 had focal segmental glomerulosclerosis, or scarring of the kidneys. So this isn't as high as that 9 out of 10, which is a bit frightening. However, it's still quite significant. But there are just things to note with the study that we'll get into first. So first we'll just, as I explained what FSGS is, it's essentially damage to the filtration barrier, well, the cells that make up this filtration barrier, and that's why the patient will have something called proteinuria, where there's proteins in the urine which shouldn't be there because proteins are usually too big for these filters, but if there's damage to them, they're let through. And so there are different types of FSGS. There's primary, or they call it idiopathic because they don't know what actually caused this progression, so they just assume it's called primary. A secondary means it's second to insult. So in secondary FSGS, which is what this would be, what these cases would be, since they're assuming it's second to steroid use, but it could also be secondary to infection or secondary to drugs, more specifically common drugs like non-steroidal anti-inflammatories or just anti-inflammatories like your ibuprofen and things. And then there's familial FSGS, which is incredibly rare, but that's just where there's a genetic link. So the first study, so that 2010 study, what do they conclude from it? Their conclusion was interesting. It wasn't very correct, but we'll get into that. So they noticed that none of these patients, or only a few, had hypertension or high blood pressure, but in fact most of them were normotensive, meaning they had normal blood pressure. And usually high blood pressure is a cause of FSGS, but there's something they did notice, and that's all of them had high BMIs, and by high I mean over 30. One had 27, but the rest were 30, 40, even in the 40s. And the fact that their BMI was so high would also contribute to FSGS, because obesity is inextricably linked to it. And I'll get onto the pathophysiology of how that works. So they concluded from the study that it's most likely due to high BMI, but they can't exclude the possible nephrotoxic, meaning kidney toxic effects of steroids. But again, there were so many confounding variables, such as their age, other medical conditions that weren't included, that it's difficult to make a concise conclusion, and they couldn't obviously pin a direct link. So, and also these individuals had extremely high protein intakes of 300 plus grams a day, and high protein intake is known to be a contributory cause of FSGS. So whilst the study isn't great, there's no harm in being extra cautious. Back onto obesity and FSGS. How is it related? Well, it's been studied quite extensively, and they found that those who are obese, besides some having insulin sensitivity, now diabetes is a major cause of FSGS, but they also found that in obesity it was mainly angiotensin 2, which we'll get on to, is the main driving factor of this, as well as they noticed that transforming growth factor beta, which is as stated, an anemic growth factor and not really relevant for what I'm about to discuss. But again, there is something they left out in the study, and they didn't leave it out, they only included it in the Saudi Arabian study, and that was that a lot of I think most, if not all, of the participants reported continual use of anti-inflammatories. One case mentioned that he had been using 600 milligrams of ibuprofen a day for 2 years, which is extremely unhealthy, not only for your gut your stomach lining and the gastric ulcers and things like that, but again, as I said, it's mostly linked to interstitial nephritis, but it obviously has been linked to FSGS. So now onto the interesting discussion. So firstly, is it reversible? So the issue with this is larger mammals, it's a bit different in smaller mammals where they actually have the capacity to regenerate nephrons, but with humans, the nephrons you're born with are there forever, and if you damage them, that's damage forever, which is the scary part which is why you want to be extra cautious with your kidneys. So for the most part, podocyte, these cells that cause the filtration barrier, is not reversible. They found that it actually isn't reversible for the most part. However, restoration could possibly occur in the blood vessels themselves by lengthening or branching. So they looked at various different methods or interventions to perhaps reverse FSGS, but they only found that these methods slowed down the progress, and once you had it, it was a progressive disease that usually progressed. But they found things like blocking that angiotensin 2, which is, remember, as we said, obesity was the driving cause of FSGS and obesity was this angiotensin 2, but so they found that by inhibiting this, it would slow down progression greatly, and that is through the use of angiotensin receptor blockers, or ARBs, such as your losartan, valsartan, and things like that. Furthermore, in other studies, they found that the percentage of scarring also had an indicator, in that if there was less than 50% sclerosis, that it was possible of growing new capillary loops, or these blood vessel loops, and that these mesangial cells, which exist within the nephron or around the nephron in this capsule, were able of proliferating after injury. But the podocyte, again, does not have any regenerative capacity. So if we can't really cure it once you have it, how do you prevent it? So the two main things that, if you look it up anywhere, how to prevent FSGS, it's limiting your protein intake. You really do not need 2 grams per pound, or 1.5 to 2 grams per pound of body weight. It actually, they suggest that it should be from 1 to 1.5 grams per kilo of body weight, and even 2 per kilo is still quite high. So limiting your protein intake would be extremely beneficial for limiting the progression. And I'll do another video, but you actually don't need as much protein as you think you might. So that's number one. Don't overdo your protein. And the second point, which they showed in the other study, is maintaining a healthy BMI. That's the problem in bodybuilders and those using anabolic steroids, is their BMI is extremely high, and although it's not fat, muscle is also strenuous on the body, even more so than fat in most circumstances, actually. And this has been shown to be there's a causative link between the two. So maintaining a BMI of less than 25 would be best case scenario, but and being above the 30 BMI range, so being obese, is not ideal. And then lastly, we'll look at new research. So those previous two topics, those are the mainstay of preventing it, but obviously you want to know if there are drugs that could possibly prevent it. And in bodybuilders, obviously controlling your blood pressure is one main way, because blood pressure is linked to it, so ensuring you are normotensive most of the time, and ensuring during workouts that you remain normotensive as much as possible, because during something like, let's say like a leg press, your systolic blood pressure could go all the way up to 400 milligrams mercury, milliliters mercury, and that in itself, those intermittent high blood pressure spikes could cause damage. So by reducing your blood pressure during workouts, so obviously control your blood pressure. There are tons of different ways of doing this. I'm not going to suggest one. It depends on the individual, and I would advise you see a physician if that does concern you. And obviously control your blood pressure during workouts. Now this, most people do it through the use of vasodilators. So there are natural ones and ones that aren't natural. So your natural ones would include L-citrulline, arginine, things like that. Those have been shown to reduce blood pressure and cause vasodilation. But there's also pharmaceutical products such as Cialis. Now I'm not suggesting it, however, I would do more research into that, since taking it as a pre-workout could lead to fewer spikes in your blood pressure. So lastly, let's look at these angiotensin receptor blockers. And obviously, as we learned, they could possibly reverse it or slow down the progression. So is it possible for it to prevent it? So, as we know, the excessive angiotensin 2 production is responsible for the development of or scarring in the kidneys, as well as it contributes not only to that, but this angiotensin 2 also contributes to cardiovascular disease. So there was a study, and I'll link it below, in which they found that angiotensin receptor blockers were quite protective of the kidney, and the most protective was telmisartan, and that was because it provided superior reductions in proteinuria to others like losartan. And however, even when they had patients who all had the same blood pressure, so you'd assume the risk of renal injury would all be the same since they all have normotensive blood pressure, the telmisartan group had much less kidney damage, and that was because the telmisartan has a higher receptor affinity and longer half-life in the plasma, so it exists a lot longer, and it is lipophilic. So that means it can cross barriers easily within the blood. So that is the best for protecting yourself against against kidney damage. There are others, such as metformin, and whilst research is limited, they actually found that whilst it's obviously beneficial in people with diabetes because it maintains normoglycemia, it could in fact, there was a study, and I'll link this one also below, in which they found in people who were already normoglycemic without diabetes had protective abilities from it. Now, again, I'm not suggesting the use of these drugs, but I'd look into it and perhaps suggest to your physician if you are putting your body at risk through the use of anabolic androgenic steroids. And lastly, a very new compound are Sglt2 inhibitors, which essentially inhibit glucose absorption reabsorption within the loop of the nephrons in the kidneys. So by reabsorption, I mean glucose is pushed out of the blood and filtered and then is reabsorbed, but this Sglt2 inhibitor prevents that. And at the same time, it prevents a bit of sodium reabsorption, so it also has found to be protective of cardiovascular outcomes. But they also found it to be, in one very small study, they did find it reversed kidney injury. So this is a very novel agent, and it does look very promising in reducing edema within the body through the mild diuresis it causes, as it's not a typical diuretic, but it does cause diuresis, which can be beneficial for the kidney. So in conclusion, steroids could possibly